We are live now.
Yeah. So good evening, everybody. On behalf of IAGE Tamil Nadu chapter, I welcome you all to the 15th focus webinar by IAGE TN chapter. So today's the focus of discussion is going to be adenomyosis. As we all know how endometriosis is now being very rampant, the same way even adenomyosis, we are seeing quite a lot of cases. So it is also again becoming an enigma, and with improvement in our understanding in this particular disease, and also with the aid of technology, we are able to tackle this particular disease very well these days. So today, to highlight on the particular aspect of adenomyosis, how to diagnose it and how to manage it conservatively, and how to take care of the fertility and how to clear them surgically, all of which, and the variant forms of adenomyosis like the acute would be discussed today in the next 1.5 hours. So here I welcome our chairperson of Tamil Nadu chapter IAGE, Dr. Korean sir, for his welcome address. And sir.
Yep.
Yeah.
Hello, good evening, everybody. Welcome to our TNIAGE webinar. I must give full credit to Mala and the team for organizing the 15th focused webinar. I think we are about the only society going through so many focused webinars. So today we've got a very interesting topic of adenomyosis, and I'm sure many of you will have many questions and doubts as to what is happening, what could happen, and what should happen. Whatever it is, adenomyosis is very interesting, and in the course of the meeting, we can discuss all the other finer aspects. So without much further ado, let's go on with the invocation and then start with the talks. Over to you, Mala. Thank you.
Yeah, thank you so much, sir. So can we have the invocation, Sahiti? So we seek the blessing of the Almighty for the success of this webinar. So lighting of the lamp is symbolic of lighting the lamp of knowledge and dispelling the darkness. So may we light the traditional lamp and start our program, please. Yeah. Yeah, thank you. So I would like to welcome our OXI President, Dr. Jayarani Kamaraj, Honorary Secretary, Dr. Kundavi Shankar, all our esteemed speakers, and also the chairpersons for this webinar. Before starting the first talk, I have a very important announcement. Sahiti, can you please play that video? Kindly pause it for a moment, please. Yeah. So this is a very interesting international webinar, which is going to be organized by IAGE Tamil Nadu chapter, spearheaded by our chairperson, Dr. Korean Joseph, which is going to happen into 2024, August 28, 29, 30, and September 1. This is going to be one of the best international conferences, and we are going to have it in the ITC Hotel Chennai. So with lots of activities, we have workshops on various focused workshops on various sectors of laparoscopy, like we have prolapse, we have workshops, we have robotic workshops, and also to enhance the suturing skills, we have the suturing workshop as well, and 2 days of scientific session and a full day of live workshops. So we have all international faculties who would be coming down to Chennai. So please do join us, block the date, and come and benefit from this wonderful conference. We are looking forward and getting geared up for this wonderful conference. Please do come over and join us. So thank you. So as we get started, so sir, do you like to say something for this, Korean sir?
No, nothing. Go ahead with the.
So, so we like to get started with this webinar, the focused webinar on adenomyosis, and the first speaker for the day is going to be Dr. Vimi Bindra, and I would like to welcome our chairperson, Dr. Jayamala, to introduce Dr. Vimi Bindra. Dr. Jayamala is the current president of the Salem Society of Obstetrics and Gynecological Society, and she is also the assistant managing director of the Rainbow Hospital for Women, and she is a phenomenal endoscopic surgeon, and she has got several accolades to her credit. So over to Dr. Jayamala to introduce Dr. Vimi Bindra and take it forward. Thank you.
Thank you, ma'am. Thank you for giving me this opportunity today. It's my honor and privilege to introduce our speaker, Dr. Vimi Bindra. She's from Hyderabad, India. She is a SASIC accredited master surgeon, multidisciplinary endometriosis care. She's a consultant endometriosis laparoscopic and robotic surgeon at Apollo Hospital, Hyderabad. She's a director of COPE, Center for PCOS Endometriosis, founder of the Endometriosis Foundation of India. Her areas of interest is an excision surgery for endometriosis, fertility enhancing minimally invasive surgeries, and she leads a multidisciplinary endometriosis team. She's a co-founder of the support group Endo Crusaders, and she's a recipient of so many awards like Young Clinician Award, Best Emerging Gynecologist Award, and she got her Vaidya Shri Award as well. She's a faculty for so many workshops, and she's organized and conducted live workshops. And she has authored some books as well. With that short introduction, I would like to call upon Dr. Vimi Bindra to give her talk on adenomyosis spectrum, imaging and surgical correlation, and its impact on clinical decision making. Yeah, thank you, Dr. Vimi.
Thank you, Dr. Jayamala, for the kind introduction. And good evening, everyone. Thank you, TN IAGE and Dr. Malaraj, for this fantastic opportunity. And this is a very important topic which really needs a lot of discussion and brainstorming so that we can offer the best to our patients. So clinical spectrum of adenomyosis, I'm going to discuss the details of it and how patients present to us and what are the management options we can offer to them. My screen is visible?
Yeah, very well.
I have nothing to disclose and no conflicts of interest. Adenomyosis is not a one-size-fits-all condition. It presents a spectrum of manifestations from mild to severe and can affect individuals differently. Understanding this spectrum is crucial for tailoring the treatment plans to individual patient needs. There is a lot of discrepancy in There's a lot of discrepancy between diagnostic performance and intraoperative findings. Many a times we have heard that patients were taken for myomectomy and it was adenomyosis. Why this discrepancy and why the preoperative diagnosis is not being done is a question which needs to be addressed, and we need to find a solution for this by proper training and getting a proper preoperative imaging done. We should incorporate more diagnostic intervention studies as there is a lack of emphasis of diagnostic studies on accuracy and where they fit in the journey of endometriosis and adenomyosis. We should aim for understanding and learning standardization of imaging using IDEA, MUSA, IOTA guidelines, which are not so complicated. And we should always follow a systematic and uniform reporting. So in our practice, we follow NCN #NCN classification and MUSA criteria for endometriosis and adenomyosis patients, and we follow a uniform reporting for our patients. We know adenomyosis is a benign condition and is classified into diffuse or focal adenomyosis depending on the extent and location, as well as the histological classification. Surgical treatment of adenomyosis remains a subject of discussion and debate. It causes significant symptoms such as dysmenorrhea, chronic pelvic pain, dyspareunia, menorrhagia, and infertility. It also causes adverse fertility and pregnancy outcomes. But adenomyosis is no longer a histopathological entity, and it's a clinical condition which can be diagnosed by clinical suspicion and imaging without surgical intervention. Earlier, it was believed that it can only be diagnosed on histopathology when the uterus is sent for pathological examination. But with imaging techniques and following certain guidelines and MUSA criteria, we can diagnose adenomyosis on imaging very well with the transvaginal ultrasonography. So what is the adenomyosis spectrum? What are the different varieties of adenomyosis we see in our practice? A very subtle abnormality, which is a junction zone abnormality, and is often missed, and these patients really suffer with severe dysmenorrhea, with disproportionate dysmenorrhea, more than VAS scores of 10 on 10. Adenomyosis and its variants, the inside-out pattern, which can present as focal adenomyoma, adenomyosis, diffuse adenomyosis, adenomyosis coexisting with DIE, endometriosis. 42% of endometriosis patients may have adenomyosis coexisting with it, so it needs to be considered. Focal adenomyosis of outer myometrium, JCA or ACOM, and atypical adenomyosis. Now, if you look at the imaging spectrum of all type of adenomyosis and the surgical correlation, how we deal with them. The junction zone abnormality, usually if you look at the hysteroscopic picture, it looks like a claw-like appearance. Diffuse and focal adenomyosis, all of us are very well aware of, and when it coexists with DIE, it's very difficult to manage as well. There are a lot of things involved with the surgical management of adenomyosis as compared to endometriosis. Focal adenomyosis of outer myometrium, it is often missed. In 37% of the DIE patients, we may find focal adenomyosis of outer myometrium, where relative sparing of junction zone happens, and it behaves differently from the usual adenomyosis. Symptomatically, it is different. The management-wise, it is also different. JCA or ACOM, which is often misdiagnosed as fibroid, and because it is smaller in size and left untreated, and patients do suffer with severe pain and dysmenorrhea, and atypical adenomyosis. If we look at junction zone abnormality, a thickened junction zone is defined as a precursor to adenomyosis. A serrated junction zone seems to correlate with image-based changes in the junction zone and inner myometrium. It is often said that adenomyosis starts from the junction zone, but junction zone abnormality is itself an entity and should be addressed for clinical correlation and patient management. As I said, on hysteroscopy, we often found a claw-like appearance. This is a typical feature of junction zone abnormality. And when we did a laparoscopy for such patients, we invariably, 90% of the patients, we found early endometriosis as well. A common pitfall to diagnose junction zone abnormality is caused by transient uterine contractions that can mimic either T2-weighted hypointense bands perpendicular to the junction zone or focal thickening of the junction zone. In those cases, the repetition of MRI acquisition may help to differentiate a physiological condition from adenomyosis. A junction zone of less than 8 mm generally allows clinicians to exclude the presence of adenomyosis, whereas a junction zone of 8 to 12 mm identifies the condition of adenomyosis if other criteria are present. This was an old definition of junction zone thickening. But now the junctional zone morphology is more important than the thickness. So a junction zone of less than 8 mm generally allows clinicians to exclude the presence of endometriosis is not correct. Basically, it is the irregularity and the discrepancy in the normal junctional zone is more important, and you look for it when you find a patient where imaging is negative, patient has disproportionate dysmenorrhea, none of the medications are working. Look for the junction zone abnormality on 3D and 2D scans and you will find it. Disruption of junction zone endometrium continuity provokes adenomyosis, a condition that causes chronic inflammation and fibrosis, which negatively affects the normal function of junction zone endometrium. Imaging by MRI and 3D sonography can diagnose junction zone abnormality, alterations in thickening and contractility frequency. So usually how these patients present, they are young patients, age group is 25 to 35 years, typical history of dysmenorrhea, visual analog scale of 10 on 10 for last 7 to 8 years, usually do not present with menorrhagia, and there is a use of multiple cycles of OCPs, GnRH analog, progestins, and dynoges, and invariably they come to us with negative imaging. So for these patients in our practice, Mirena has helped a lot, and if they are associated with early endometriosis, excision of endometriosis, and help these patients with Mirena insertion. So what are the future research questions for this type of abnormality? Will all these patients develop adenomyosis? We need to follow them for a longer term to know that all junction zone abnormality patients develop adenomyosis or not. What is the best treatment modality for them? Still not known. And will hysteroscopic resection help if not trying for conception or family is complete? Junction zone thickening or abnormality, which is more important. And by recent research, we know that junction zone abnormality is more important rather than thickening. So 8 millimeter criteria is no longer valid, even if the 5 millimeter thickening is there, but it is abnormal, morphometric changes are there, look for it and diagnose it. Adenomyosis and its variant, the inside-out pattern, we very commonly see focal adenomyosis, diffuse adenomyosis with multiple myometrial cysts. The focal adenomyosis is the most easiest to treat, and it behaves like fibroids or leiomyoma. And whenever you do hysteroscopy, you will see the adenomyotic changes in the uterine cavity as well. So focal adenomyosis usually can be completely excised, and it behaves like fibroids. The only thing we have to keep in mind is that whenever we are excising focal adenomyosis, we should keep a 0.5 millimeter to 1 centimeter distance from the serosa. Similarly, from the endometrium, we should keep a distance of 0.5 millimeter. And focal adenomyosis, the results are very good, the surgical results as compared to diffuse adenomyosis. Their fertility outcomes are good, the pain scores improve, and the healing of the myometrium is also very good as compared to the diffuse adenomyosis. So here you can notice the endometrium, and even if the endometrium is open, there is nothing to panic about it, and make sure that you are 0.5 millimeter to 1 centimeter away from the endometrial cavity whenever you are excising a focal adenomyoma or diffuse adenomyoma. Adenomyosis, again, diffuse adenomyosis with DI is very, very common. In 42% of patients, we see adenomyosis and it needs to be addressed. Definitely, adenomyomectomy is not the first treatment options for these patients, but there are certain indications where adenomyosis has to be done. And this patient we did a robotic double flap adenomyomectomy where the uterine volume was more than 500 cc. Severe pain scores, multiple failed IVF treatment, and there was no space for embryo implantation as well. So debulking surgery was done. And from 500 cc, we brought the uterine volume to 200 cc, and patient did conceive successfully after the surgery as well. Adenomyomectomy surgery is still controversial in European countries if you look at the literature, because there is no long-term data on the adenomyomectomy surgeries. The reproductive outcomes and the live birth rates and the complications related to adenomyomectomy, still the data is lacking. But in Asian and Indian subcontinent, a lot of adenomyomectomies are performed with good results, but definitely publications need to be there to support our data also. So this was a double flap adenomyomectomy where we debulked the disease, and patient had a huge improvement in her symptoms. The VAS scores from 10 by 10 became 7 by 10. And she, as I said, that her embryos were frozen and she conceived as well after the surgery. She's around 24 weeks right now, and we are looking for a good pregnancy outcome as well. Now, this is another case where, again, diffuse adenomyosis was there, and the pre-surgery, it was 232 volume of cc, and post-adenomyomectomy, it was 149, and you can see a beautiful endometrial lining developed after the surgery. Adenomyomectomy is surgically challenging because of the obscure boundaries between the normal myometrium and the adenomyotic lesion. Intraoperative blood loss is more technical difficulty with suturing tissue planes to eliminate the dead space at the operation site. So robotic does help in such cases where suturing and approximation is much easier as compared to laparoscopy. So indications for adenomyomectomy are dysmenorrhea and hypermenorrhea, infertility, recurrent miscarriages, failure of medical treatment, multiple IVF failures, implantation failures, and desire to preserve fertility or the uterus. Factors related to uterine rupture, adenomyosis removal method. We are using cold knife for powered instruments, degree of extrusion of the adenomyosis, extent and size of the uterine muscle defect, method of reconstructing the uterine cavity and the uterine wall, postoperative wound infection and hematoma formation, and period of contraception prior to postoperative pregnancy, and the scale of the surgeon is most important. There is another conservative technique which we use for diffuse and focal adenomyosis is microwave, laparoscopic and ultrasound guided microwave ablation. Still experimental and in research, but we have started doing it with the patient consent, and we have seen good results over a period of 1 year postoperatively. There is almost 70% reduction in the preoperative volumes. Usually how these patients present, they are young patients and reproductive age group, perimenopausal age group also, 20 to 50 years, typical history of progressive dysmenorrhea and menorrhagia, history of use of multiple medications again with OCPs, GnRH analogs, progestins, and dynages. If infertility, multiple failed attempts at assisted conception and IVF failures too. So adenomyomectomy and its results on quality of life and reproductive outcomes as prospective multi-center study needs to be done, and results of minimally invasive surgery for adenomyosis, robotic and laparoscopic comparative studies needs to be done on the long term. Coming to a very important presentation of adenomyosis, it is an outside-in pattern. It is also called as focal adenomyosis of outer myometrium. It is also called as endometriosis of the uterus or the DIE of the uterus. If you look at the different layers of the uterus, the cavity is there, and then the endometrium, the inner myometrium, middle myometrium, outer myometrium, and the subserosa. So this involves the outer myometrium and the serosa and subserosa, but it does not involve the inner myometrium and the junction zone. So there is a relative sparing of junction zone in focal adenomyosis of outer myometrium. So behavior of this disease is different. Identification of ultrasound is different. So transvaginal ultrasound shows the question mark sign, which signifies a fixed non-mobile anteverted retroflex uterus with the fundus adhered posteriorly to the rectum and or sigmoid colon. MRI image shows outside-in pattern of myometrial involvement with relative sparing of junction zone. It is also called as focal adenomyosis of outer myometrium. These are ultrasound images and these are the MRI images. If you look at it, it very clearly spares the junction zone. It only involves the serosa and the outer myometrium. We have a very good experience of managing this foam, and multiple cases we have managed. We have also sent this for publication. We are awaiting the publication of a series of 30 patients where we had done the foam excision. This is different than diffuse adenomyosis. In these cases, usually as the serosa is completely involved, it is not possible to create the 2-layer or 3-layer as we do in adenomyosis cases. So in this, we excise the abnormal tissue and approximate the normal myometrium. And in most of these cases, it is also possible to completely excise it as compared to the diffuse adenomyosis cases. This is another case where, again, if you look at the images, this is the focal adenomyosis of outer myometrium. This is the junction zone, and there is again the relative sparing of the junction zone. This is the focal adenomyosis of outer myometrium, and this is a robotic picture of foam, which was excised completely in this case as well. So this is a study group. This is our own data. We had an age group from 24 to 44 years with a mean age of 30.4 years. The mean length of duration of menstruation was 4.5 days with a range of 3 to 7 days. Mean age of onset of symptoms was 30.4 years. Family history of endometriosis was noted in one patient, and 80% of patients had regular cycles, which is 73.3% had normal flow during periods. Patients mainly presented with symptoms of dysmenorrhea with an average of 6.3 on a scale of 10 according to VASA score, and 39.6% had taken treatment for infertility and 90.8% had failed IVF. On follow-up of all these patients for a period of 6 months, significant reduction in VASA scores Of 46.2% women who were trying for pregnancy, 9.48% of them conceived. One patient had recurrence of pain symptoms. None of the patients had recurrence of lesions in 6 months follow-up on imaging. So thickness of junction zone is an important factor for heavy menstrual flow. And as our patients had foam, which does not involve the junction zone, they did not have complaints of heavy menstrual flow. And 80% of patients had regular menstrual cycles. These patients are young patients. The age group usually is 20 to 40 years, typical history of progressive dysmenorrhea, painful defecation, infertility, multiple failed attempts at infertility treatment, and IVF failures too. Now, the future research questions in this type of adenomyosis is form a phenotype of adenomyosis, or it should be regrouped as endometriosis. It should be excised with DIE or left alone. We need a comparative study to answer this and long-term outcomes of home excision. Transvaginal sonography is the first-line imaging to diagnose adenomyosis. It has been shown to be sufficiently accurate when using histopathology of hysterectomy specimens as the reference standard, as seen in a recent meta-analysis which reported both sensitivity and specificity to be 78%. Coming to JCA and ACOM, I think it will be discussed in detail in one of the talks today. And this is most often misdiagnosed as fibroid uterus, and this usually varies in size from 2 to 3 centimeters, and patients are, most of the time they are dismissed and they're told this is fibroid and nothing to be done, no surgery is needed, no treatment is needed for this. But if you do a ultrasound, proper ultrasound, you can see this blood collection inside the mass, or on MRI, you can see even fat-sat hyperintense images on MRI. It is very easy to detect. These hyperintense images can be picked up easily, and this has very good outcomes. Once excised, the recurrence is almost nil, and patients have very good quality of life and fertility outcomes as well. In our study, most of the cases we had left-sided JCA or ACOM, and very rarely on the right side. These patients are very young patients. Age group is 20 to 30 years. JCA is typically less than 30 years as per definition as well. Typical history of dysmenorrhea, VAS scores of 10 on 10, and one-sided pain, they complain, usually do not present with menorrhagia. They also are given multiple medications because nobody wants to operate for these small fibroids, but actually they're not fibroids. And future research questions are, can we develop a protocol to detect these young women with JCA at the earliest? So this is a very interesting case of an atypical adenomyosis with junction zone abnormality. This patient came to us from UK, and she was operated 6 months back only for DIE excision or early endometriosis excision. So they found early peritoneal endometriosis, and that was excised, but her pain was very severe on one side. This was on the left side. She early had pain. If you look at the normal robotic image, this looks like a normal uterus and there is no abnormality. But if we revisit the imaging showed us that there was an abnormal area of myometrium. This was the local or focal adenomyotic area, which was also involving the junction zone. And we went in, and because none of the medications were working, she had taken Leupride, Zoladex, multiple GnRH doses, progestins, OCPs, everything she had tried, but nothing was working. And we went in and excised that area, and the repair was done. Patient is 8 months post-op, and she's doing wonderfully well without any pain, and she may try to conceive as well. So here the imaging helped us to find this abnormal area. Otherwise, it is very difficult to find such areas in a normal looking uterus. So if a good imaging is done preoperatively, you can detect these abnormal areas or atypical location of adenomyosis, excise them completely, and patients usually have very good outcomes. And 2-layer suturing was done. We usually use V-lock for the suturing. This is one of our study where we had done preoperative mapping and structured reporting of pelvic endometriosis as per the #NZN classification, which also includes adenomyosis. FA is the adenomyosis component we use for, and we found a very good correlation on imaging as well as surgical findings. Other than peritoneal endometriosis, all the parameters were more than 90%. sensitive and specific as well. Now, coming to MUSA criteria, it's a very important and very good criteria for diagnosis of adenomyosis. The revised definition of MUSA features of adenomyosis and the distinction between direct and indirect signs should facilitate recognition and diagnosis of adenomyosis in clinical practice. The updated definitions are important for future studies on relationship between the MUSA features of adenomyosis and clinical symptoms and reproductive outcomes. So what are the take-home messages from this clinical spectrum? Providing precise anatomical information about the uterus with respect to zonal anatomy in correlation with clinical symptoms gives clue for early diagnosis. Morphology over morphometry analysis of junction zone will aid in early pickup, look and not measure. Minimally invasive approach to fertility sparing management of diffuse adenomyosis is safe and feasible with good anatomical results. Patients should be advised on the risk of uterine rupture during pregnancy after adenomyomectomy before the procedure. Multicenter prospective studies using standardized surgical procedures are needed to confirm the effectiveness of adenomyomectomy. A multidisciplinary approach to adenomyosis management is essential. Radiologists, surgeons, gynecologists must collaborate closely to ensure a comprehensive understanding of the condition, accurate diagnosis, and effective treatment planning. This collaboration bridges the gap between imaging, surgical intervention, and clinical care. Healthcare professionals can develop tailored treatment plans that address the unique needs of each patient. Multidisciplinary approach helps optimize patient outcomes by ensuring that all aspects of adenomyosis are considered, leading to more informed clinical decision and personalized care. It also facilitates open communication and exchange of expertise among different specialties to achieve the best results for our patients. Future research areas in this context are isolated junction zone abnormality targeted needs to be developed. Can detecting junction zone abnormality prevent development of early diffuse or diffuse adenomyosis? Massive diffuse adenomyosis in teenagers and younger population. What causes such rapid growth of adenomyotic tissue and what is the ideal treatment for them apart from hysterectomy? Thank you. And also I'm sharing a link. We have developed a survey on for gynecologists and radiologists. It is a joint study of EL and EFI, and I'm putting the link in the chat box, and I request all of you to submit the survey and help us do this study so that we can have a better understanding of MUSA criteria and its usage throughout the globe. Thank you.
Thank you, Dr. Vimi. That was an excellent, elaborate talk on imaging, how we have to focus in our imaging when we diagnose adenomyosis. I just have one question that, yes, you have spoken about all these focal adenomyosis and all the other things. The diffuse adenomyosis, what is your criteria apart from the patient's symptoms? What is your criteria to operate on diffuse adenomyosis?
The patient symptoms, you said apart from patient symptoms, one is size of the uterus is important. Patient symptoms are also important. Coexisting DIE, if she has multiple failed treatments, multiple medical treatments are not helping, and patient wants to preserve the uterus, then we go for adenomyomectomy.
Is there a particular volume that you will go ahead and operate on diffuse endometriosis?
We usually tell our patients that 70 to 80% reduction of the adenomyosis we can do, but not 100%. Definitely, it's not achievable. So as much as possible, we'll do that.
Thank you.
So that was a very excellent presentation, Dr. Vimi.
Thank you.
The biggest challenge is when we have a young girl coming with adenomyosis, that too, which is a diffuse adenomyosis, and with a normal junctional zone. So in such a situation, what do you do?
We always try first medical treatment. That was I kept in the research questions also, because very young patients we are getting, like in 20s, they have big uterus, 16-week size uterus, 20-week size uterus, very difficult and challenging. We always try medical treatment first. If it's symptomatically better, as long as we can continue, we continue. Surgery we keep as the last option. Definitely.
Yeah, so if she's like 12 years, 14 years, where the bones are not still closed, so which would be your ideal drug for her?
Only progesterone. progesterone-based treatment.
Dynogest is, but
Dynogest also I would avoid. I usually prefer medroxyprogesterone acetate. Dynogest also causes a bit of bone loss, so after 18 years only we prefer.
Yes, that is.
So medroxyprogesterone acetate is the most preferred drug in that age group.
Right. So when do you think you will operate on these girls?
If none of the medicines is working and her quality of life is very bad, or we can also try Mirena for younger girls. Mirena also works very well. Even if they're of teenage group, we can try Mirena as well. If that is also not working, very big uterus, Mirena expelled out, then definitely will operate.
Okay. Any criteria on the volume of the uterus you look at?
It's not the volume, because sometimes we have seen where even a small diffuse adenomyotic area can also cause severe symptoms. As I showed in an atypical adenomyosis case, she had taken all medications and pain was so severe, she was not able to walk also. And there are patients, sometimes they come with a 20 weeks uterus and they are not symptomatic. So it's not the volume, it's basically the patient's symptoms, what she is looking for, what is her age group, and what we best we can offer. We tailor the treatment according to her age and requirements.
So in case of foam, so what do you think it is? This is like outer wall is what is involved. So what do you think is the origin? There is always a debatable thing whether it is coming from the inside or it is coming from the outside. So what do you think? It is the inside one going to the external, or the external coming to the myometrium?
So it's mostly basically the posterior compartment disease which climbs onto the uterus. It's not that the internal disease which comes out. It's mostly the posterior disease which starts from the posterior peritoneum to the uterosacral ligaments, and it climbs onto the torus utrinus and goes to the posterior uterine wall.
So most of the time it is only the DIE. So when a patient has a DIE, we should obviously look for foam, right?
Yes.
So
That's what I said. 37% of our patients had foam.
Foam, yeah. So anyway, good, very, very clear presentation. So Korean sir, you'd like to add something? So you're muted, sir. So you're muted. You have to unmute yourself.
Yeah.
Okay.
Can you hear me?
Yeah. Very well, sir.
Okay. I think she's covered most of the topics, but the basic problem in the whole thing is, one side you say junctional zone thickness, and then you say you must not get into the endometrial cavity. Now, how do you decide where to stop? The decision is going to be arbitrary. So the surgeon acts like God and decides where to cut off. So how many cases have you followed up later to see what has happened and how much of the junctional zone has been retained after all these fancy surgeries?
No, sir, I didn't say not enter the endometrial cavity. You can enter the endometrial cavity. There is no problem. I said don't panic if you enter also. Just leave a endometrial cavity. If it is badly damaged, junctional zone is gone, we cannot help much. So in those cases, we just keep a manipulator inside, we repair it. And if patient is looking for symptomatic relief, we tell them that pain scores won't become 0. Definitely pain scores will reduce. If you have 10/10, it may become 4/10 or 3/10. It won't become 0/10. So definitely some residual disease will always be there. But if junctional zone is also involved, as I said, in junctional zone abnormality, yes, implantation failures will be much, much higher as compared to cases where the junctional zone sparing happens.
Yeah, but then suppose if you are, you are trying not to open the endometrial cavity, but if it is open, are you going to suture it back or?
No, Dr. Bala, we don't suture it back. We just...
Yeah, but there are literatures where they say that you have to suture, because even in fibroid, we do not close the endometrial cavity at all. But couple of papers, they have really closed the endometrial cavity, because I am in the concept that if you close, you are going to add the iatrogenic adenomyosis component again to the patient. But then there are people who are closing. So what is your thought on that?
In our practice, we don't close, and we have done follow-up scans and excellent results in terms of the endometrial cavity, the triple line cavity we get. So we never close it.
Yeah, I too don't close. Okay, so someone has asked a question. So what is the limit of your excision? How do you differentiate between the normal and the pathological tissues?
First is imaging guides us. If it is foam, it is very easy to identify a normal endometrium, normal myometrium and an abnormal myometrium. You can excise it completely without even disrupting the endometrium. You don't even have to go to that because it is in the outer myometrium, inner myometrium sparing happens, and suturing is also wonderfully well in foam cases. Diffuse adenomyosis is only the difficult challenge where anterior wall may be less involved, posterior may be more involved, or vice versa. So in that case, you have to see the volume of the walls and decide which wall you are going to dissect more. As I said, 0.5 to 1 centimeter from the serosa and 0.5 to 1 centimeter from the endometrium, you should retain and suture it well. And the suturing should be good to give the good strength to the uterine musculature.
So according to you, which is the best surgical technique for a better scar integrity?
There is no one technique best over the other because there are no randomized trials and there is no comparative studies done. So it all depends on the skill of the surgeon, the suturing skills, how good you are at suturing, how you obliterate the dead space, how you reduce the hematoma formation, which will give rise to good results.
Yeah, so what do you do, the flap technique or you do the wedge resection? What kind of?
I do double flap or triple flap for adenomyosis. Diffuse adenomyosis. For foam, I don't do a flap technique because it's not possible. The serosa is completely involved. So I just shave it off and suture the myometrium.
Okay, fine. I think we covered. Anything else, sir? Korean, sir, you want to ask anything?
No, nothing. Go on.
Yeah? Okay, yeah.
Dr. Asha Rao here. Mala, there was a small
Hello,
comment.
madam. Good evening, madam. Yeah.
Good evening. Good evening, Mimi. It was a wonderful lecture regarding the endometrium. If you look at Osada's technique, he always opens the endometrial cavity. And then they suture it also in triple flap. And according to him, the chances of rupture were almost 0 in his series. And pregnancy rates were 55%.
Yeah,
So
the current concept is not to open the endometrial cavity, madam. So the Osada's was the triple flap technique. Now we have the other techniques where you do not do the
Osada always opened the endometrial cavity.
He did, yes. He did, but then there are few more techniques which have come up after Osada also now, where the cavities are not open. So we just affect only the adenomyotic tissues, something like the 4-petal and, different kind of techniques are there.
No, but the purpose of Osada's technique was to know how much of it is left. Because if you don't open the endometrium, you just don't know where you've reached.
But then ultrasound, that is what post-operative ultrasound is very important. After we extract the tissue, we can do an ultrasound to see how much of the adenomyotic tissue is left behind, how much is the normal myometrium, and then that helps. But maybe for Osada during those days it was not available.
The most techniques are trying to mimic Osada's technique laparoscopically. What he did by laparotomy, they are trying to do by laparoscopy. But by laparotomy, they had the tactile sensation, which was a much better advantage. Of course, we would not like to open up women as much as possible. That's true.
Very often at laparoscopy, what happens is it is not intentional, but the endometrium gets open.
Yeah.
Because we don't know exactly where we are as you are dissecting. So endometrium gets open and we try to approximate it. We need not switch endometrium to endometrium, but you have to suture the myometrium area above that so that the cavity is reformed. And this is not intentional. But as because the junction zone is the abnormality, as you are dissecting more and more, you definitely will come near the endometrium. So it's likely, we are not intending to open the endometrium, but it does happen.
Yes, madam. So I think we have covered all the aspects. Dr. Vimi, thank you so much for being with us and sharing your valuable thoughts. And thank you, Dr. Jayamala, as well, for chairing this session. So we move on to the next topic. May I invite Dr. Kundavi Shankar to introduce our next speaker, Dr. Madhupriya. Dr. Kundavi Shankar is a very renowned fertility specialist and a senior consultant in AAA. And she is also very academically sound and has a vast experience in reproductive medicine. So over to Dr. Kundavi Shankar to introduce Dr. Madhupriya.
Thanks, Mala, for the invite. And it's my pleasure and honor to introduce one of my colleague and my fellow who's done the fellowship from AAA. And she's a fertility consultant from Nova Hospital. She's had a diploma gynec laparoscopy from Germany, fellowship from AAA. And she's got a lot of papers, posters from 2007, and a lot of publications and special interests like biological for poor ovarian and sperm reserve patients on fertility. Over to you, Madhupriya.
Thank you, ma'am.
Good evening, one and all. At the outset, let me thank the IAGE team, Dr. Korean Joseph sir, Dr. Malaraj ma'am, Dr. Kundavima, for having given me this opportunity to talk about fertility challenges in adenomyosis and its management. The incidence of the roller coaster disease in women, the adenomyosis, has an incidence of 20% in those women less than 40 years, whereas the incidence has peaked to about 80% in those at or above 40 years of age, especially the subfertile women who are trying to get pregnant and they are symptomatic with adenomyosis. As there was a shift in the fertility and fertility treatment towards an age group of more than or equal to 35 years of age, when there was a shift in fertility treatment for women seeking fertility beyond 35 years of age, about 60% being about 35 years of age, we see an increase in the incidence of adenomyosis detected more in the reproductive age group. As we all are aware, the trans-abdominal ultrasound with improving imaging modality leading to trans-vaginal and now with 3D and the MRI has been able to assess and delineate the diagnosis of adenomyosis in infertile women. With 63% sensitivity and poor image resolution, not a very reliable factor in diagnosing adenomyosis or in differentially diagnosing adenomyosis from the uterine fibroid, the trans-abdominal ultrasound is now given up and the trans-vaginal ultrasound, which is commonly available for definitive diagnosis, is being used. With the addition of 3D to the trans-vaginal ultrasound, the images have been sparklingly clear, just like that of an MRI. There are characteristic features like asymmetrical myometrial thickening, the linear striations as we see here, the myometrial cyst which we can observe, the hyperechoic islands that we see, and the acutely S-shaped endometrium that we see in adenomyotic uterus is suggestive of the presence of the disease. But in reproductive age group women, the junctional zone is the major marker. With any abnormality in the junctional zone, whether it is hyperplasia or abnormal thickening or abnormality in the junctional zone or destruction of the same, the endometrial myometrial interface is a clear sign of adenomyosis in symptomatic subfertile women, constituting up to 50% of signs being very clear of adenomyosis. So in the normal MRI picture, we see that this yellow line is the uterine cavity. The outer brown layer is the myometrium with the junctional zone in between the two, which when is hyperplastic results in increased uterine hyperactivity at the junctional zone. The increased uterine junctional zone hyperactivity usually results in a high impact on the reproductive outcome with a very, very poor outcome whenever there is a proportional increase in the hyperactivity in uterine zone. An aberrant endometrial metabolism that happens within the adenomyotic diseased area leads to destruction of the normal myocytes, leading to changes in the architecture and function, which in turn causes high intrauterine pressure together with the junctional zone hyperperistalsis, leads to a highly oxidative stress containing uterine environment that can suppress the endometrial function and decrease the uterine receptivity. So the decreased uterine receptivity and the lower implantation rate in a reproductive age group women with adenomyosis can be attributed to the decreased expression of adhesion molecules necessary for implantation, namely the integrins, selectins, cadherin molecules, and also the implantation markers, especially the interleukin-6 and the LIF factor, and along with these, the abnormal functioning of the HOXA10 gene, which is a gene necessary for implantation, has also been altered. Not only a poor receptivity of the uterine endometrium, but also a poor embryo development is observed in symptomatic subfertile adenomyotic women with or without associated endometriosis, and this has been attributed to the abnormal pro-inflammatory response, increase in the pro-inflammatory factors, altered expression of the estrogenic and the progesterogenic receptors, resulting in high free radical environment in the uterus, leading to a damage. Even if a woman with symptomatic subfertile adenomyotic woman conceives, there is a higher early pregnancy miscarriage rate, which is double that in a woman without adenomyosis, and nearly 3 times lower clinical pregnancy rate when compared to women without adenomyosis, resulting in very poor live birth rate and ongoing pregnancy rate. So far, so many studies have been done in adenomyotic women, but the evidences from these studies have been obtained from women who have undergone IVF or ICSI to improve their reproductive outcome. So very little is known about the treatment challenges in natural cycles or IUI, especially in adenomyotic women without associated endometriosis or associated tubal factor abnormalities. However, medical treatment so far is considered as the first line of treatment for adenomyosis, bewaring the complications that could happen with the minimally invasive surgeries or the conservative surgeries or the adenomyomectomies. The aim of medical therapy in a subfertile adenomyotic woman has been to reduce the production of endogenous estrogen and induction of the progesterogenic action of endometrial differentiation. Let us see one by one. The medical treatment, NSAIDs, it's a magic drug for pain relief in adenomyosis. But as far as the fertility outcome is concerned, it has got negative effects by delaying the rupture of the ovarian follicle. Coming to the combined oral contraceptive pills, it's a drug that's helpful in treating the symptoms of adenomyosis, be it metorrhagia, menorrhagia, or dysmenorrhea, but it has very limited data on the impact of subsequent fertility improvement. This is helpful to use contraceptive pills to suppress or downregulate the endometrial receptors and start them with the HRT in the next cycle, especially in those women who have undergone IVF ICSI and are about to enter the frozen embryo transfer cycle. The next molecule is the ADENOMYOSIS, again an anti-inflammatory drug with hypoestrogenic and hypergestogenic activity. This in the long term has been suitable to decrease the symptoms of an adenomyotic patient. Again, a magic drug which is able to reduce the pain and the suffering of the woman to such a much greater extent. But whether a fertility outcome following an IVF or ICSI post-ADENOMYOSIS therapy is yet to be driven. Coming to the commonly used GnRH analogs, yes, it's helpful in reducing the size of adenomyotic lesions. It helps in improving the endometrial implantation market, but these are transient effects and there is a disadvantage of rapid regrowth of adenomyotic lesions after the medicine is stopped. The continuous use of the GnRH analog has been rapidly suppressing the LHFSH, resulting in hypoestrogenic environment in the uterus, decreasing the volume of the disease. Nevertheless, pre-treatment with the GnRH analog is rewarding in patients with adenomyosis, especially those undergoing ART cycles, and especially better in those undergoing frozen embryo transfer. A new oral GnRH antagonist, the linzagonid, which is also seemingly helpful to reduce the volume of the disease and treat the pain and the bleeding subsequently, has not been proven to improve the reproductive outcome post-treatment. Studies are needed to comment on the same. When the first line of treatment, like the ADENOMYOSIS, continuous contraceptive pills, or the LNG IUS systems, are not much helpful, fertility sparing, minimally invasive surgeries, especially for younger women and those with localized adenomyosis, are used, especially the hysteroscopic cytoreduction of the localized adenomyosis, use of endometrial ablation along with the LNG IUS while you give a gap between the ART procedure and the frozen embryo transfer, hysteroscopic resection of the cysts or the crypts within the uterus before going ahead with the frozen embryo transfer cycle, or the use of high intensity focused ultrasound or the uterine artery embolization, knowing its disadvantages and finding out patients whether suitable for the particular procedure is important. The use of LNG IUS system, pre-treatment with the same in women undergoing ART cycles, have been found to enhance the implantation rates and the clinical pregnancy rates, with double improvement in ongoing pregnancy rates. The use of high-intensity focused ultrasound, helpful in young patients with local adenomyosis, but is not much suitable for the diffuse adenomyosis. It's helpful through the coagulative necrosis that it does at the localized area. Nevertheless, in combination with the GnRH analogs, HIFU has been helpful in decreasing the symptoms and the size of lesions, but has the disadvantage of decreasing the ovarian reserve in the future. Hysteroscopically see and treat policy of looking at the cysts and the crypts of adenomyotic lesion and correcting it by either dissection or coagulation prior to ART frozen embryo transfer is helpful in improving the reproductive outcome in the adenomyotic woman. When an ART with appropriate medical treatment, appropriate hysteroscopic procedures or minimally invasive surgeries have not been helpful in giving a good reproductive outcome, we go on the third line of management, the fertility sparing surgeries. With different types of uterine sparing surgeries available, the type 1 more towards the localized adenomyosis, and this involves complete eradication of the disease, and it's easier to do compared to the type 2, which is a difficult surgery, not aware of the boundaries, not aware of the involvement of the endometrial lining. There is a high chance of entering the uterine cavity, risk of destroying the functional endometrium, risk of not maintaining the uterine integrity, resulting in preterm rupture during the future pregnancies, have been only a cytoreductive surgery and not a complete cure. Depending on the type of techniques that one really does, the surgical cytoreduction using triple flap, double flap method, the modified Osada's technique, all these have been helpful in increasing the postoperative pregnancy rate from various studies quoting between 20 to as high as 70. But most of the studies quote that associated artificial reproductive technology has been responsible for the high pregnancy rate in such cases. Though there is an improvement in the fertility outcomes after surgical treatment of focal adenomyosis or after the diffuse adenomyosis as well, quoting around 30 to 50% increase in the reproductive outcomes, the combination of GnRH analog medical therapy perioperatively, especially with the conservative surgery, have given more effective, longer durable symptom control along with the better reproductive performance in such women. So as far as the ART is concerned, with a milder adenomyosis, using standard ART cycle with GnRH analog, oocyte retrieval and cryopreservation done following which hysteroscopic treatment of the cysts or the crypts if necessary, followed by medical treatment for 2 to 3 months to downregulate, and then going ahead with a frozen embryo transfer for 1 or 2 cycles is seemingly found to increase the reproductive outcome. The use of endometrial receptivity array in such patients have also improved the understanding of the receptivity of endometrium. If there has been failure of the ART cycle with a frozen embryo transfer, giving another try of GnRH analog course is recommended. Whereas in moderate to severe disease, if following the oocyte retrieval and cryopreservation with or without the hysteroscopic treatment of cysts and the GnRH analog course, if there has been multiple repeated implantation failure, then if less than 40 years of age in the lady and she has a localized adenomyosis, surgical treatment is contemplated. Whereas if the woman is more than 40 years and has a diffuse adenomyosis which can not much improve the reproductive outcome, then the trial of further cryopreserved embryo transfer after a GnRH agonist course is suggested. Until today, with all the information available to treat a subfertile symptomatic adenomyotic woman, the treatment of such a woman is still a maze because the time to conceive post-treatment, whether medical or surgical, is unknown. The decreased endometrial receptivity following surgical procedures and minimally invasive procedure is high. There is a decreased live birth rate, which could also be contributed due to the uterine rupture, which is iatrogenic, and because of preterm delivery. And there is a subtle, unavoidable risk of premature ovarian insufficiency due to the use of embolization techniques, and certain unclear details till date about how long should the fertility treatment and pregnancy be delayed after the treatment for adenomyosis, and whether a hormone treatment per se after the surgery will improve the fertility outcome for sure. Whatever we have seen is just the tip of an iceberg in the treatment of subfertile symptomatic adenomyotic women with recurrent implantation failure, and there needs to be more effective, safe, less invasive managing strategies which are still to be explored. Thank you so much for the opportunity.
Thank you, Madhu, for the lovely presentation. I think you just told us about the findings, the factors involved, and the management during ART procedures. If I'm allowed to ask you a question, suppose people have said that you have a question mark endometrium, right? The S-shaped cavity and other things. Practically, how do you go about the transfers? Because you need to have a larger catheters. So what is your practical take on that?
I still use under ultrasound guidance. I've been using the flexible catheters. I prefer using an afterloading technique, and I definitely do a trial transfer in such patients. If I find a grade 1 or grade 2 difficulty as well in such patients, I definitely go ahead with a general anesthesia in such patients. And I've also been very liberal in the use of the PCBs, the paracervical blocks, which have been able to give a easier, smoother flow of the catheter into the cavity in such difficult adenomyotic patients.
Does the length of the uterus, when you measure, then you go with the medical or a surgical treatment to reduce the volume before you go ahead with the transfers? If so, what would you prefer, whether a medical or a surgical?
I'm more towards a medical management in such cases, ma'am. And if the volume is really high with severe diffuse kind of an adenomyosis, I would give them GnRH analog for a period of 3 months before I go ahead. And in case of mild adenomyosis, and if the ERA is suggestive of a receptive status, I still go ahead with one cycle of combined oral contraceptive pills and down-regulating the hormones before going ahead with the transfer in the frozen embryo transfer cycle.
People talk about agonist plus the letrozole. What is your experience on that?
I have not used letrozole along with the agonist, ma'am, but yes, in those people with endometriosis, letrozole and GnRH analogs have been helpful, especially in reducing their symptomatology people who have been having so much of dysmenorrhea have been able to get it controlled. Dynogest and letrozole with GnRH has been helpful. But prior to the frozen embryo transfer cycle, I've used only GnRH analog and the combined oral contraceptive pills to down the release.
What's the role of atosiban just before the transfers? Because we know that the endomyometrial junction you have on waves in order to prevent ectopic pregnancies. So your experience on atosiban?
Ultrasound guided transfer is the best route, as we all know. And instead of 0.5 to 1 centimeter below the fundus, which is usually given for a routine frozen embryo transfer cycle, I use it about 1.5 centimeter below the fundus, usually to prevent, because there is a depth of endometrium in a diffuse adenomyosis especially, wherein there is a chance of ectopic pregnancy happening. So usually place it around 1.5 centimeter below the fundus of a severely adenomyotic uterus.
Suppose if the patient is undergone, because you have all the lab surgeons here, so when would you start an FET following a surgery?
Usually 3 to 6 cycles later in case of a severe adenomyosis. In case of course, a laparoscopic surgery is contemplated after the oocyte cryopreservation or the embryo cryopreservation, only after which we contemplate on the surgery. After surgery, 3 to 6 cycles of GnRH long duration therapy, following which the frozen embryo transfer is done for severe adenomyosis. In case of milder adenomyosis with or without surgery, I give them 3-month cycle, after which I go ahead with the frozen embryo transfer.
You are talking about LNG, right? So how many months of LNG you would pace before an FET?
I've just had 1 or 2 severe adenomyosis where they required LNG IUS, and I've kept it for them for about 8 to 10 months before I went ahead with the transfer, removing the LNG IUS and giving them again a very minimal dose of estrogen and progesterone, and seeing if the endometrium grows better, and then going ahead with the frozen embryo transfer cycle. So about 8 to 10 months, after which I went ahead with the transfer.
Thank you so much, Madhu.
Thank you, ma'am. Thank you so much.
Dr. Kundevi, I just had one comment to make, Dr. Madhupriya, regarding the combination of Dr. Asharav here, regarding the combination of OCP plus GnRH and log, I do not think it's really favorable. OCP is not helping at all. But if you combine with letrozole and GnRH analog, it's much more useful. For severe cases, we have used sometimes in a patient with 340 cc and 12 centimeter uterine cavity length. We suppressed her for 8 months with GnRH analog and lithium. And her uterine cavity length came down to 9 centimeter, and we transferred, she had a conception. But the OCP will not give you this result when you use it along with GnRH analog.
Yes, ma'am. Thank you for that comment, ma'am. And this was in mild adenomyosis, which we use only the combined oral contraceptive pills. And I said my experience in mild adenomyosis, where a combined oral contraceptive pills I give before going ahead with the frozen embryo transfer, especially if the ERA is done and I find that it is receptive, I go ahead, ma'am. In case of the letrozole and GnRH, I've not had an experience. So I've only used GnRH against.
Yeah, I was talking about severe cases of resistant adenomyosis.
Yes, ma'am. Yes.
Yeah. Thank you. Lovely talk.
Mala, Badhu was talking about the cystic adenomyosis where you go about hysteroscopic. How do you all do that?
Yeah, so it is like how we do an endometrial ablation. So using a resectoscope, either monopolar or bipolar, you can use the resectoscope, and this just cystic portion alone you can just resect and remove it. And then after that, you can put them on Mirena for a couple of months for the volume also to reduce. And then maybe after that, you can start your fertility treatment as Dr. Madhu was quoting. So I have a video in my presentation. I will show you how we do the hysteroscopic resection.
Thank you.
So that was a very good presentation, Dr. Madhu, and very clear cut. And so I think we'll move on to the next presentation. Like, can Meenakshi take over? We welcome Dr. Meenakshi Sundaram. to take the next session.
Mala,
Yeah.
the next talk is by Dr. Mala, and we have Dr. Satyanarayan, who would be
Meenakshi, your volume is very low.
low, is it? You
Yeah,
can
yeah.
hear me?
Yeah,
Now
yeah.
you can hear?
No. Little more louder, please.
Okay. I think my comp is showing the maximum volume. Any better now?
Yeah, much better, yeah.
Okay. All right. Mala, can you get back to,
Yeah.
we welcome Dr. Satyanarayan he has done his UG/PG from JIPMER, and he is here to chair this session, which is his main interest is laparoscopy and hysteroscopy. And he's here to introduce Mala for her talk. Is he there in the...
Yeah, so Dr. Satyanarayana. Oh, yeah, he is, sir is there. Yeah.
Sir, can you unmute
Doing one
yourself?
Yeah.
This is an extreme pleasure and a unique opportunity for me to introduce Mala Raj, already who's very familiar with all of us. He is the founder secretary of our current IAGE chapter, and to her credits, a lot of other things, and she's one of the very erudite surgeon to say in a very least format. Taking much more time, I would hand over the session to Dr. Mala Raj.
So thank you so much, sir. Before I start my presentation, Sahiti, can you play the Apache video? So here I would like to welcome you all for this Apache conference, which is going to happen next year. That is in Yeah, go ahead. So this is the conference which every endoscopic specialist, fertility specialist, urogynecologist, and minimal invasive surgeons, vaginal surgeons should attend. So do block your date for next year, 2024, August 28, 29, 30, and September 1 in Chennai, ITC Grand Chola. You have to really attend this to benefit quite a lot and also to enjoy the conference. So save the date and keep yourself free for that. Okay, so we move on to our presentation. So thank you so much, Dr. Satyanarayana, sir, for the introduction. So, of course, my topic now is going to be on the surgical technique in adenomyosis. Quite a lot of discussion has already happened on adenomyosis and the surgical part of it. But still, let me add a few more on the surgical aspect. Of course, as we all know, the appropriate surgical management for adenomyosis is still a matter of discussion because there are many factors involved to it when it comes to fertility and other things. Because of the recurrent nature of the disease, still we are not satisfied how much ever we resect the adenomyotic tissue. So that is the challenge when it comes to adenomyosis surgery. And since 1990, of course, earlier it was only the V-shaped resection which was performed. And but now we have various kinds of technique which was being discussed in the earlier session, talk as well, where the uterine muscle flap, asymmetrical dissections, and various other modified reduction methods have also been done, a few of which I would be highlighting in my presentation. And this adenomyomectomy now has become an alternative to laparotomy, and especially for the focal type of adenomyosis. And of course, even in diffuse adenomyosis, laparoscopy is now considered as a gold standard. So, so why this adenomyomectomy is a challenge? So when it comes to myomectomy, it is quite fine. Like you have to just resect the myoma and you're able to approximate the myometrium and suture and reconstruct the uterus beautifully. But then in case of adenomyosis, it is not so because of the pathology. The tissues are so friable. Sometimes if you do not resect in the appropriate manner, you may find it difficult to approximate the serosa. That is the challenge in adenomyosis. And also when it involves the fertility, again, the chances of rupture is very high in this particular surgery compared to that of a myomectomy. So that is the reason we need to follow the right technique. So it is considered as an enigma ever since Rokitansky described in 1860, and it has gained quite a lot of attention over the past few years. Of course, thanks to our technology, because of the excellent 3D and the MRI, now we are able to diagnose adenomyosis much earlier, and also we are able to correctly depict what exactly is going to be inside when you introduce the scope, which was very beautifully demonstrated by Dr. Vimi Bindra. The correlation between the preoperative picture and the laparoscopic findings would be exactly the same. So once we have to decide on the surgery for adenomyosis, we need to really understand the disease. So only then we'll be able to offer the appropriate surgery. So what we need to understand here is that there is no basement membrane separating the endometrium from the underlying muscle layer. As explained, it was only the junctional zone which has, excuse me, sir. So the main problem here will be the junctional zone. So it is the invagination of the junctional zone into the myometrium, and it can mainly occurs because of the disruption, and the disruption can be either because of various factors when the intrauterine pressure goes up. This increase in the intrauterine pressure can occur even during normal menstrual cycle. It can also occur during the normal delivery or cesarean section, or during any kind of procedures like a DNC or any kind of hysteroscopic procedure as well. So this leads to a various cascade of reaction and causes tissue injury. That is where the TR effect comes. Now this TR mechanism is mainly the crux of the development of adenomyosis. Apart from that, there are various other hypotheses also which has been described, like the epithelial mesenchymal transition at the interface between the myometrium and the endometrium, and also various other aberrations in the endometrial and the myometrial component. So earlier, when we had a patient with adenomyosis, most of them were in the premenopausal age, and hysterectomy was the only treatment which was offered. But now we are seeing younger women seeking fertility treatment. So as a result, we need to offer them conservative treatment as well. And also with improved diagnosis, we are able to pick it up. And also because of the delay in the pregnancy, because the women are trying to delay the pregnancy, again, it becomes a challenge. So about a third of the patients with adenomyosis are totally asymptomatic, but sometimes they present with pain and abnormal bleeding and also infertility. And most important thing is that it is associated with other challenging diseases like endometriosis and fibroids. So we have double and triple challenge when we deal women with adenomyosis. So many women, when there is a constant association between adenomyosis and endometriosis with an incidence of about 3 to 18%. And also it has been found that women who have endometriosis also have adenomyosis and vice versa. There are also correlation between the foam and also the deep infiltrating endometriosis. And also the focal adenomyosis and the focal disease are entirely different. The relation between adenomyosis and the dye have also been highlighted. So it is invariably the dye which kind of invades into the myometrium and result in adenomyosis or the foam. So the same is with the internal and the external adenomyosis. So these are the various terminologies which are coming up with adenomyosis for proper differentiation of the treatment. Because if it is going to be an internal adenomyosis where the junctional zone is going to be involved, we are going to manage her hysteroscopically. And if it is going to be the external variant, then you have to go manage them laparoscopically. Of course, the MRI also has helped us to subdivide them. And based on this, the intrinsic, extrinsic, intramural, and the indeterminate adenomyosis. And based on these subtypes, we are going to tackle them. So the preoperative evaluation plays a very, very vital role when you are dealing with women with adenomyosis. Of course, ultrasound is the crux, followed by then MRI to determine the size and the location, and also the depth, how much of the myometrium we need to excise, and also plan our surgery. And this helps us to plan our surgery very well. So in adenomyoma excision, the most important point what we have to keep in mind is that we have to preserve the myometrial reserve. Like how in endometrioma, we preserve the ovarian reserve. Here we have to make sure that we preserve the myometrial reserve. So how much of myometrium is going to be left behind after the surgery is very, very vital. So hysterectomy is no longer offered. Try medical treatment as far as possible is the first choice. If not responding, only then we resort to surgical management. So of course, type 1 adenomyomectomy is very simple. Focal adenomyoma, just remove only the adenomyoma and it is wonderful to reconstruct it. But when it comes to type 2 adenomyomectomy, which is diffuse, that is when the challenge arises, when the entire uterus is involved. So we need to know where exactly to draw the line and finish the procedure. So pre-operative evaluation is very important. Consent plays a very, very vital role because this needs to be clearly discussed with the patient that the chance of rupture during pregnancy with this particular surgery is going to be high. So she should be under close surveillance with the obstetrician with whom she is taking the treatment. And also the thickness of the involved wall should be also be measured pre-operatively perpendicular to that of the endometrium, both before and after the surgery. So we need to also mention how much of the myometrium we are leaving behind at the end of the surgery. That is the reason I mentioned the myometrial reserve plays a very vital role in case of adenomyomectomy. And also, though it is a minimally invasive surgical technique, it has found to have tremendous relief. Even some amount of adenomyotic tissues, if you remove, she will have tremendous relief from pain, bleeding, and also her fertility would improve. So, of course, type 2 adenomyomectomy, here various techniques have been described because this is mainly for the diffuse adenomyosis. So you have the Osada triple flap technique, you have the 2-flap technique, the U-shape technique, and various kind of techniques have been described. But the aim of each and every surgery is that we have to maintain the myometrial wall thickness, maintain the uterine layer alignment, and the endometrial integrity. This is where there is a conflict, as the discussion went on in the previous session. So whether to open the endometrium or not to open the endometrium, as far as possible, the current concept is not to open the endometrium. If inadvertently, if we open the endometrium, we are not going to suture it. We suture the myometrium overlying the endometrium. So the principle of surgery is that here the continuity of the adenomyotic lesion from the endomyometrial interface to the myometrial layer occurs. So the surgical boundaries are usually obscured and very difficult to decipher. So how do you find out which exactly would be the healthy myometrium is by your palpation. We can differentiate the stony heart from the healthy myometrium and also from the color of the healthy myometrium. And also we need to preserve the tissue for adequate repair to avoid functional hysterectomy. Invariably, most of the time, most of the myometrium is chopped up, so that we ends up with a very small uterus, which is not even approximated properly. That is the reason the technique has to be very clearly defined. So the good exposure of adenomyotic tissue is the first step for the success of the surgery. However, the challenges in this particular procedure is that we have a very poorly defined surgical plane. We do not have a capsule as we have it in fibroid surgery. And also it is difficult to identify the adenomyotic tissue. The endometrial cavity can very easily be entered because the adenomyotic tissues are very fibrotic. And also the optimal way to close the uterus to reduce the future risk is still very, very unclear. That is why various techniques are available. So what is that we have to follow the principle and approximate properly following the right surgical principle. So here I present a very nice technique called the 4-petal technique, wherein you make a cruciate incision on the uterus and excise the adenomyotic tissues and approximate the uterus in layers. So here you can see that the adenomyotic tissue, invariably most of the time the adenomyosis will be in the posterior aspect. Also because of the gravity and invariably because of the associated endometriosis. So here you can see that the adenomyotic portion of the uterus we injected with pitocin. Of course, they'll also have some amount of chocolate cyst, and this is she had no surgery. She's an early gravida, but still the inflammation has produced so much of adhesions. And then you have to clear the adhesions first, get the anatomy right, and then clear the pelvis, and then proceed with the adenomyomectomy. So here we make a horizontal incision on the myometrium, the serosa and the myometrium, and then the vertical incision. So this becomes a cruciate incision. So the whole idea is that we are going to create a flap and excise the adenomyotic tissue. So here the incision is now extended right up to just above the endometrial cavity. So this is actually a T-shaped incision, not the 4-petal technique. So here we are excising the adenomyotic tissue. So the serosa, 5 millimeter of the serosa should always be left behind for proper approximation and also to prevent rupture. Same way the endometrium, you should stay 5 millimeter above the endometrium. So how are we going to identify where exactly is the endometrium? If you want, you can inject some amount of methylene blue in the endometrial cavity, which help us to define where exactly is the endometrium. And also the palpation of the tissue will also help us to differentiate between the healthy myometrium and that of the endometrium. So once you excise these adenomyotic tissue, then you have to approximate them and suture and reconstruct the uterus. So this is the inverted T-shaped incision technique and not the 4-petal technique. The 4-petal technique will be in the next one. So the adenomyotic tissues are all clearly excised, and finally we can reconstruct the uterus. So the reconstruction of the uterus should be in such a manner like it is very different from that of myomectomy, because here we'll not be able to close it as we close in myometrium. So you have to try to take it deep through and through suturing of the myometrium and the serosa in a single layer, and then come over 2 or 3 layers. So the bite should be really deep, like unlike that of myomectomy suturing. And then finally, we have to make sure that the entire uterus is reconstructed. Try to avoid as much as possible the energy sources, because that will weaken the scar and will result in the rupture if she is planning a pregnancy. So finally, the tissues are put in a bag and removed inside the bag. Again, very important aspect. So this is a technique where you can inject again pitocin for hemostasis purpose, and then a horizontal incision and then vertical incision both above the horizontal line and the below. Again, it is extended, so you get a cruciate incision. So once you get a cruciate incision, it becomes like a 4 petals of the flower. So all the petals will now be opened up and then catch hold with the grasper, and then the adenomyotic tissues you can clearly identify now, and then you can excise all the adenomyotic tissues from each and every petal. So this is a basic advantage with this particular technique, because the exposure is very good. The earlier days, because we were not able to expose, the most of the times the entire uterus were chopped off and it resulted in a functional hysterectomy. Now, because we are able to identify all the adenomyotic tissue, we are able to excise all the diseased portion of the uterus. And then finally, once it is done, then of course follow the principle of about 5 millimeter above and 5 millimeter below, so that you give a safety margin both for the serosa and for the endometrium. But still inadvertently you can enter, but then doesn't matter. Don't suture the endometrium, suture the myometrium above the endometrium. So all these adenomyotic tissues are now being excised, and then once you excise all this adenomyotic tissue, then we have to only approximate the tissues. So here I generally use the barb sutures are very good, because here the traction should be very uniform, because if you're going to use the real smooth sutures with intermittent, there will be uneven tension on the muscle, and as a result the tissues can even give in, and there can be tearing of the tissues, which can be avoided if you're going to use the barb sutures. So with barb sutures, you can reconstruct the entire uterus, and you can avoid any dead space. And once you are done with the initial deep sutures, and then finally you can take 1 or 2 sutures above with a smooth suture to make sure that the barbs are held in place. So this is a case where you had the patient came with a recurrent endometriosis with adenomyosis, and you can see how the uterus is stuck to the pouch. The total pouch posterior compartment is obliterated. In such a situations, we have to go retroperitoneal. So because the most important thing is here, the bowels are adherent very densely. It is like a frozen pelvis. So we have to mobilize the bowel. The best way to approach these bowel is to mobilize them retroperitoneally from the virgin area that is above at the level of the pelvic brim. Identify separate the bowel from that of the lateral pelvic wall. Then we can identify the most important structure which we have to keep in mind here is the ureter. There is a fair chance that the ureter can get damaged while you are doing the adenolysis if you are not very careful. So here you have the iliac vessels, and then here you have the ureter. So you can see the peristalsis of the ureter. So the peritoneum over the ureter is opened, and then you have to do an ureterolysis. So where the ureter is lateralized and the bowel is medialized, so you have a very clear plane. So once we open it by going retroperitoneal, you can see that the entire bowel will fall off medially, and the ureter also goes off laterally. Then we are in a very safe zone to mobilize the uterus. So then the adhesion on the uterus can be separated with the help of the harmonic scalpel, or you can use any shearer, whichever you're comfortable with. And then again, the same is repeated on the opposite side. Identify the ureter, mobilize the ureter, then you do an ureterolysis. So the ureter stays away from the harm's point, and then finally separate the bowel. So in this way, the bowel also will be separated very comfortably without any damage to the bowel. So this kind of lysis we have to. So in such, most of the time in adenomyosis, we have an associated endometriosis. So we should be able to tackle that as well and remove this adenomyotic nodule. So this adenomyotic nodule is now being again excised with the 4-petal technique method, where the adenomyotic tissues are now being excised, and then once it is done, and then the uterus will be reconstructed, and you can see at the end of the surgery, the uterus is thoroughly mobilized. The integrity of the bowel is also being checked, and you can see that the ovaries are also mobilized in this situation. She had a recurrent endometriosis, and finally the tissues have to be removed in a bag. So this is a case, in fact, again, an infertility patient. So you can see this is, so that is the reason why for all infertile patients, you have to do a hysteroscope. This was an incidental finding. She was posted for endometriosis surgery, and you can see how the junctional zone is. So such was the situation, and you can see the adenomyotic tissues all over the entire endometrial cavity. So this is going to be a real problem for this particular lady. So this kind of an endometrium would definitely hamper her fertility. So this is how the adenomyosis would present hysteroscopically. So, and of course, she also had all the endometriotic lesions to be removed, and we had to also take care of her tube as well, which had gone in for hydrosalpinx. This is a woman who had completed her fertility, and she had this polypoidal adenomyosis. This is adenomyosis intrinsic adenomyosis, that is interna, which was being discussed in the previous lecture. So So you can see how the endometrium is adenomyotic, polypoidal, cryptic, and you have the fierce looking endometriosis. So these endometriotic tissues, you have to excise them with a resectoscope. And then once here they present with abnormal uterine bleeding and severe dysmenorrhea. So once these endometrium is resected, and it, of course, they will also come out as polypoidal adenomyosis. So you resect all of these and then send it for biopsy. And then finally, we can put a Mirena to make sure that her condition does not recur immediately. So the entire endometrium would be ablated and you can give them Mirena. So these are the various other hysteroscopic view of adenomyosis. These are infertile patients where incidentally we get to see all these things. So we know how to manage them. So do not lose an opportunity to introduce your scope in all infertile patients who complain of pain. So here again, you have a frozen pelvis where the uterus is totally stuck and you have a chocolate cyst and deep infiltrating endometriosis. You have to excise all the endometriotic lesions and finally excise the adenomyotic nodule. So the most, again, here we are doing the flap, the 4-petal technique, and then finally reconstructing the uterus. Here, while doing the 4-petal technique, the most important point is that we have to take care of the junction, that is where the cross is being made, where the cruciate incision is being made. We have to be very careful. That point we have to approximate properly to get the uterus to normal shape. So ideally speaking, in these situations, once you reconstruct the uterus with the barb sutures, finally it is always better to take a vicryl stitch intermittently, just 1 or 2 stitches on each limb, so that the uterus, none of the barb sutures would give way inadvertently as well. So you can see that there won't be any raw area exposed and the entire uterus will get its final shape. So this is the advantage of the 4-petal techniques. So, so again, these are adenoma. So this is the difference. So in case of a fibroid, you will excise a fibroid and approximate it myometrium to myometrium. But in case of adenomyoma, you have to take in the myometrium, then 1 bite into the serosa, then the myometrium. So it has to be deep through and through suturing. So that is the difference between myoma suturing and adenomyoma suturing. So these are the various benefits of the petal, where the exposure is good and you also have a clear dissection. And of course, post-operatively, the patient are symptomatically, they fare very well. The pain and dysmenorrhea and menorrhagia are gone. And how much of myometrium is to be retained? That is what I meant. Myometrial reserve has to be maintained. So always maintain 0.5 millimeter or 1 centimeter. So this 1 centimeter from the serosa, 1 centimeter from the endometrium, or at least 0.5 millimeter has to be done. If you are in doubt, you can do an ultrasound at the end of the surgery and confirm whether you have whether you are doing an over excision or under excision. So adhesion prevention again plays a very, very vital role, because with a good surgical technique and minimum tissue handling, you can avoid all of these. And of course, if there is a hemostasis is well secured, only then you apply Intercede. Then post-surgery outcome, obstetric outcomes, high miscarriage rates, thinning of the uterine wall. Of course, the miscarriage rates have dramatically come down after the surgery, but still it is there. And then silent midterm uterine rupture is what one needs to keep in mind, which is very different from that of a myomectomy rupture. And of course, other placental disorders like accreta and percreta can also occur. So this risk of rupture can be minimized if you avoid tissue damage and proper energy. So, suturing. And of course, cases of uterine rupture, 23 cases have been reported in this particular OSADA study as well. And then adenomyomectomy or medical adenomyomectomy, which would be preferred. That is, GnRH analogs is also considered as an medical adenomyomectomy. So the study have demonstrated that conservative surgery was effective, whether or not the patient has received any kind of a medical treatment. So this is again a wedge resection where a portion of the these are very clean cases where it is a focal adenomyoma. You can excise them like that of a fibroid. You can just make a inverted T-shaped incision and then excise the adenomyotic nodule and then finally suture and reconstruct the uterus. So the uterus would get its shape and then you can put an adhesion barrier. So this patient conceived immediately 6 months after the procedure. So this is again a acute. So most of the acute in literature, if you see, it will be described described on the lateral round ligament, but invariably even Dr. Vimy was quoting that she also had in the left. So this is also again on the left near the round ligament. So these accum, again, it is like a wedge resection only, but the most challenging here that I mean the margins will not be defined, so you have to resect it properly and make sure you suture also them. So they'll have tremendous pain relief, and again these are the adenomyomectomy. So there are various other reports where some have not reported any rupture as well with these particular techniques, and the outcomes are also kind of good. But of course, what we need to understand is what causes the uterine rupture is only a technique. It is advised to use the scissors, the cold knife, rather than that of any of the energy sources, and also how much of the tissues you are removing, and also the extent of the defect, and also how you reconstruct the cavity, the post-operative infections, the hematoma formation, and what is the period of contraception prior to post-operative pregnancy, and the skill of the surgeon. All these things only will define the risk of rupture for that particular case. And of course, wound healing is getting disturbed if you use excessive electrocoagulation. So that is the reason we are trying to avoid energy sources as far as possible, the monopolar and the bipolar. Of course, even mechanical energy sources like the harmonic have also been found to be detrimental, but then we don't have a choice but to use it, because cold scissors sometimes becomes a big challenge. So in such a cases, you have to use them. And of course, wound healing is mainly because they have found that the collagen in these tissues are very deficient. Similar to that in case of the cesarean section, that is what the histopathological study have shown. So that is the reason we have to be very careful while we are suturing, and also while we are coagulating. And also the contraception prior to the post-operative period, when exactly we can allow these women to get pregnant. So the most important thing is in fibroid, we can say 3 months, but in adenomyomectomy, always look for the Doppler, see when the blood flow resumes. So the avascular space in the uterus should disappear. Only then, once the blood flow resumes, you can allow the women to get pregnant. So there are various literatures where they have said, so for some it has taken about 12 months, some it has taken 2 years, and some even within 3 years the vasculature has resumed. So it varies. So the Doppler is the crux when we have to decide when exactly we can allow the women to get pregnant. So this is exactly the various studies, and also for better outcome after surgery, it is always, they say, better to give a GnRH analogs both pre and post operatively. Why? Because GnRH analog after surgery also will prevent the reflex of menstruation. So once the reflex of menstruation is arrested, it will not interfere with the healing of the wound. In that way, it allows the uterus, keeps the uterus quiescent, and allows the wound to heal properly, so that we'll have a better healing for these women. And of course, in IVF, it does help also. So we utilize it for that as well, and also for the healing of the wound. Of course, now CA-125, does it really have a role? So there is various schools of thought, where earlier we were using CA-125, now that is not given up, but still it does play a role, because CA-125, if measured before the surgery, it will be phenomenally high. So after the surgery, if you repeat it, you can see the CA-125 coming down. So that gives us an idea how effective our surgery was. So that gives, so CA-125, we have to do it prior to surgery. And also these conditions are associated with endometriosis and CA endometria. So for us to rule out other pathology, it is always better to do a CA-125 even in case of adenomyosis. And so these are the clinical outcome of CA-125 following adenomyomectomy. So pre-op, you can see how it is 126 and how it drastically dropped at 6 months after surgery to 16. So that is a benefit of CA-125. So ultimately, so what are the factors that are going to predict the success of our surgery? So this is the age at surgery, the visual analog score, preoperative dysmenorrhea, and the post-operative junctional zone. All these were the indicators which would indicate the success of a particular surgery. What is this junctional zone? The junctional zone should be less than 8.5 millimeters. So if patient has a junctional zone of more than 8.5 millimeters, millimeters, 20% of these pregnancy, they do not get pregnant. So especially when we have a reproductive patient, we have to ensure that we maintain all of these standards. So younger age at surgery, lower visual analog score, preoperative dysmenorrhea, and thinner post-operative junctional zone were all closely related to the post-operative pregnancy outcome. And of course, the clinical pregnancy rate in the first 3 years was really high, 70%, when the junction zone thickness was less than 8.5 millimeters. So these have a very direct implications for clinical practice. We need to keep all of this in mind while taking our patients for adenomyomectomy. More so extra cautious when it is an infertile patient, and of course in other patient as well. So where we do it for pain relief. So one needs to choose a right technique that fulfills the following criteria. That is, one which has a good exposure of the lesion, one which maximizes the resection of the lesion and tailors the myometrial reserves, one that offers and maintain adequate thickness of the uterine wall. Still, having additional conservative surgical management options for adenomyosis is a tool for clinicians, and the patients are stuck in between the rock and a hard place. This is always the dilemma for our patient and the treating gynecologist in case of adenomyosis and the particular surgery. So thank you so much for the patient listening, and I'm open for questions.
So that was a wonderful presentation to this wonderful audience. Let me set the ball rolling by asking one or two questions. If a patient is coming with an asymptomatic woman is coming, like for example, medical fitness for pre-employment, and we find some adenomyotic lesions, what do we do?
Oh, asymptomatic, she doesn't have any problem. Why at all interfere? Don't do anything to her. Just leave her alone.
In other words, when to treat or operate?
So only when she presents to us with some complaints, we have to interfere. If she's not coming out with any complaints, better not to disturb her at all.
Yeah, well said. And regarding the preoperative GnRH, how many doses would you prefer, and what will be the interval between the last dose to the surgery?
So ideally speaking, so I do not prefer preoperative GnRH analogs. I prefer to give them post-operatively. Post-operatively, after the surgery, because it also takes care of the residual diseases, and also it helps in the healing of the wound. Preoperative, if you want to reduce the volume of the uterus and then proceed with the surgery, so you should you can stop it at least 2 or 3 months prior to the surgery, and then take her up. Yeah.
Regarding rupture uterus following the adenomyomectomy, is there clear-cut evidence that the rupture occurs at the site of surgery or somewhere else?
So I don't think so. I have not come across any thing in the data, also literatures, but I think it must be at the site of surgery only, because that is a portion which is going to be weak, right? I have absolutely no idea on that.
When we see a series of rupture uteruses in a government hospital setting where I am in, many often find them rupturing at odd places, particularly the nulliparous women or the multiparous women. Sometimes they hide a past history of MTP with dilatation or, probably resulting in perforation. But I think partly the blame should go to adenomyosis after listening to this exposition today. I think I'll hand over the session back.
But somewhere I remember reading very vaguely that is in the corneal portion is what the pressure goes up, and most of the time I think you can also see the rupture happening in the cornea, but I am not sure whether it is related to adenomyosis. If anyone has any other thought, yeah, kindly share, please.
Today we had a rupture uterus for a second gravida, and we discovered that during corporal sterilization, if people can believe it.
Okay.
We had to open the UET.
Yeah.
I mean,
okay.
That's the lecture which we are having today. But of course, One is the hidden history of past medical termination of pregnancy. If definitely it is not there, then I think we can probably point towards adenomyosis. And probably she was asymptomatic earlier. We have to probably have a series of studies.
Yeah, sometimes
biopsy.
even hysteroscopic resection of septum. So overcorrection of the septum also, no? Like if the myometrium thickness is not well maintained, you can have a rupture at the time of. So hysteroscopy also you have to be very careful. So especially when you are using energy sources, if you are okay with, I mean, if you are perforating with an energy source, definitely you have to suture. You should not leave it like that and come. But scissors is okay. But then you have to be very cautious when the rupture happens with an energy source.
Points taken. Thank you.
Thank you. Thank you so much, sir. Yeah. So can we move on to the next presentation? Over to Meenakshi.
Hello.
Yeah.
Yeah, the next is another lovely talk by Dr. Padma on accessory cavitated uterine mass, which we find more frequently nowadays. And sharing this session is Dr. Sitish Ghosh. Dr. Sitish Ghosh is the Dean and Professor of OBGYN at NGM-CRI, Sri Balaji Vidyapith, Puducherry. His field of interest is minimal access surgery, mainly reconstructive gynecological surgery. And over to you, sir, for introducing the speaker for ACUM. Dr. Sitish.
Hello.
Yes, sir. Yes, we can hear you, sir.
Am I audible?
Yes, sir.
Yeah.
You're audible, sir.
Yeah, see, yeah, we can hear you, sir. Please go ahead.
Am I audible?
Yes,
yeah,
you're
yeah,
audible,
you're
sir.
audible,
Please,
so please go ahead.
I think some internet connection problem. So far it was all right. I think just before the session start, it got interrupted.
We are able to hear you,
We
sir.
can hear you,
It's
sir.
audible, sir.
I'm not able to see any slide.
Okay. Okay, so are you able to hear us?
Are you still logged in, sir?
If I can interject here,
yeah.
full Pondicherry is now out of internet.
Okay.
I borrowed this from some other
okay.
source that is, but I think there is an entire shutdown of Wi-Fi, data cable, everything is off.
Okay.
Luckily, one or two services are there. So I think we move ahead. I think you have to take over, Dr. Malaraj.
Yeah. Okay. So Meenakshi, do you want to introduce Dr. Padma?
Welcome, Dr. Padma, Senior Consultant and Head of Department of Obs and Gynae from Meenakshi Mission Hospital and Research Center, Madurai, a laparoscopic, hysteroscopic and robotic surgeon. And she was awarded a certificate for gynae oncologist and presently the Secretary of Madurai OBGYN Society. Welcome, madam, for this interesting session on ACUM. I think something which we, find a lot these days. Madam is there. She can start sharing her slides. Yeah. I'm unable to hear her audio.
Can you hear me? This is Dr. Padma.
Yeah. Now we can hear you.
Yeah.
Go ahead.
Thank you, Dr. Mala, and I thank the IAGE and Meenakshi both for the opportunity and for kindly introducing me. And we had good talks from the previous speakers, and Mala's was especially fabulous as usual. And compared to that, this is a relatively small, concise topic which has been given to me. accessory cavitated uterine mass, ACUM as you call, is isolated cavitated lesions, mostly in the lateral aspect of the myometrium and usually found inferior to the attachment of the round ligament. It is usually observed in the premenopausal women, usually less than 30 years, and these people usually present with severe dysmenorrhea with an onset soon after menarche. And some of them present as a chronic pelvic pain with a primary or a secondary resistance to combined oral contraceptive pills and NSAIDs. And when you look into the literature, ACUM goes by different names. That is juvenile cystic adenomyoma, as how the Japanese group call it. And it is also referred to as isolated cystic adenomyoma, uterine-like mass, accessory uterine cavity, adenomyotic cyst, accessory uterine malformation, cystic myometrial lesions, and uterine cystic adenomyosis. Now we know for sure that ACUM is a uterine malformation. And not necessarily, it is not a, what do you call that, when we have been talking about adenomyosis, but then this is typically a uterine malformation. And all of us are aware that the uterus and the fallopian tubes, they develop from the Mullerian ducts, and the gubernaculum forms the round ligament. And the etiology is that ACUM may be associated with the duplication or the persistence of the Mullerian duct segment at the level of attachment of the round ligament to the Mullerian system. And the other theory is it's because of the dysgenesis of the female gubernaculum, and ACUM is associated with the maldevelopment of the gubernaculum per se. And when we look into the classifications offered by the different societies, ACUM doesn't find a place, though we know now for sure that it is a Mullerian anomaly. And the American Society classification doesn't include ACUM as of now into its classification of Mullerian anomalies. And that is the same story with the HRA 2013 consensus also. And but then now it is considered as a part of unclassified uterine malformations, the U6 class. So that's a rough representation of the ACUM lesion per se. And what you see here is the uterine cavity is normal, and you can see the normal insertion of the fallopian tubes into the uterine cavity. And this, accessory cavitated uterine mass is separate from the uterine cavity and is usually seen below the attachment of the round ligament. And for the same reason, when we put in a hysteroscope at the time of the surgery and then evaluate the uterine cavity, we can always see that the cavity is normal, and we can see both normal tubal ostia on either side. So thereby ruling out any other uterine malformation, and there is no communication or association between this cavitated uterine mass and the uterine cavity. And most of the times the lesion is said to be found on the right side, but literature review says that nearly around 40 to 45% of the cases it is on the right side, and a similar number it is on the left side. And in a very few rare instances, it has even seen reported in the midline, and some one or two authors are even reported it alongside with the uterine malformations like an unicornuate uterus, a bicornuate uterus also. So the diagnostic criteria of an ACUM is it's an isolated accessory cavitatory mass which has to be associated with a normal uterus, tubes, and ovaries. And following a surgical excision, and when the specimen is cut open, it clearly shows an accessory cavity lined by an endometrial epithelium with glands and stroma, brown colored chocolate content, and of course there should not be any adenomyosis associated. And but some of the authors have reported small foci of adenomyosis within this lesion also, probably the same pathology which Mala has explained, a high intracystic pressure forcing the myometrium into the, forcing the endometrium into the myometrial mantle of the cavitatory mass itself. So once extracted, the mass looks like that, and when you cut it open, you can see the chocolate colored content within this cavitated lesion. And that's how the pathology looks like. Central cavity, which is lined by the endometrium and surrounded by a good myometrial mantle. So now, once again, we need to have a good, preoperative diagnosis, as is there for every other pathology. And here in the ultrasound, we see a clear spherical shaped cavitated lesion containing echogenic fluid surrounded by a thick myometrial mantle quite away from the endometrial cavity per se. And this lesion is located between the round ligament, insertion of the round ligament or the interstitial part of the tube and above the uterine artery. And when you put on the Doppler, we see absence of vascularity in the central part and a good vascularity in the myometrial mantle, which is equivalent to that in the surrounding myometrium. And this has to be associated with the normal uterus, fallopian tubes, and ovary as per the definition. And most of the times, these lesions are picked up in young girls in whom a proper transvaginal examination is usually not allowed or accepted. And so one has to go ahead with the abdominal ultrasound. And of course, we have the 3D ultrasound, which is as good as an MRI in picking up these anomalies of the uterine cavity, as it is always there. And in this picture here, you can see that the uterine cavity is normal, and the interstitial part of the tube has been marked by the letter I, and the accum is seen separate from the cavity and from the tubes on the same side. And of course, we can also do an MRI, and the findings here also are similar. We can see a cavitatory lesion separate from the uterine cavity, and we can see both the tubal ostia, insertion of both the tubes clearly into the uterine cavity. And this efficacy is in comparison with the ultrasound. So when we have a 3D ultrasound, it almost gives the same information as that of an MRI. We need not have to do an MRI always, except when there is doubt, and when we have in mind whether it could be any of these conditions, that is, whether it is a true cystic adenomyoma, or if there is any associated Mullerian anomalies, especially an unicarnate uterus with a rudimentary horn, a Robert's uterus, which is a septate uterus, which is however not communicating into the main cavity, or a degenerated fibroid. So that's how we differentiate between these different differential diagnoses. Accum invariably occurs only in a young girl, usually in the adolescent girl in the immediate menarcheal years, immediately after the menarche, and in nulliparous women. And we have a cavitated mass surrounded by a thick myometrial mantle, definitely away from the uterine cavity. And in histopathology, we see a cavity lined by endometrium and a surrounding thick myometrial mantle. Whereas in cavitated adenomyoma, it is commonly seen in more older women, women more than 35-40, and the focal adenomyosis is not in continuity with the junctional zone. And there is in the ultrasound and in MRI T2 images, we do see a hypointense mass compared to the hyperintense one, which is seen in T1 with the accumulations. And the other important differential diagnosis is a non-communicating rudimentary horn, which is always, patients usually are referred with that kind of a diagnosis. And in this, when we put in a hysteroscope, we know it is a single ostia, and definitely the preoperative imaging, especially a 3D ultrasound and an MRI, may help in a preoperative diagnosis. And of course, the uterine cyst, which is nothing but a simple epithelial line cyst, and it doesn't lack the thick myometrial mantle or the hemosiderin deposit there. So this is the upper picture is that of a unicornate uterus with a non-communicating rudimentary horn, and that picture down is the accum. So that is how it looks. And of course, when if somebody is not very well versed with the 3D ultrasound or a proper transvaginal ultrasound, then there can be a confusion between the two. And this is another patient, a picture from another patient, which shows a degenerating fibroid. And here also, we don't, the typical mantle of myometrial thick mantle is absent in the fibroid. And the other thing is the vascularity pattern and other things, which help to differentiate between an accum and a degenerated fibroid. And the typical placement also, location of the accum is also missing with fibroids. It can be anywhere all over the uterus. and a review of literature which has been recently published in the Journal of Obstetrician and Gynecologist as recently as 2022. The problem here with ACUM is it has been a relatively newer identified pathology. It has been existing for quite long, but then it has been given a name, and then literature has been, people have started reporting only in the last probably a decade and a half. So there is a paucity of literature, and then we don't have any, randomized control studies showing us how to manage these lesions. And most of them are only case reports, either of, ranging from a few to up to 24 cases. And as per this review, they have clearly stated the treatment choices which were offered to the patients were either a medical management or a more conservative treatment like a sclerotherapy and a surgical excision. And has already been pointed out by previous speakers, because this is also a cavity which is lined by an endometrium, and that responds well to hormonal management. Medical management, of course, can help in these people, but with the disadvantage being there can be an inadequate pain relief, and there is a recurrence of symptoms once the medication is stopped. So the same treatment as what we use for a patient with endometriosis will help. The same regimens will help here, namely a continuous contraceptive pills, oral contraceptive pills, a Mirena or a GnRH agonist. The second therapy, that is the sclerotherapy, just like how sclerotherapy has been explained for ovarian endometriosis, after putting in a needle and ultrasound guidance, the contents of the cyst are aspirated, and then the endometrium lining is destroyed by giving a sclerosing agent, usually ethanol. And the treatment of choice, however, in majority of the case reports which have been reported are surgical excision, and that gives a complete relief of symptom for the patient. And as of now, that seems to be the treatment of choice. The main advantage being the no recurrence of the problem once treatment has been given, and the mode of approach is either a laparotomy or a laparoscopy. But then considering a simple lesion like an ACUM, in comparison with that extensive adenomyomectomy which Mala was talking about, the preferable approach is laparoscopy. So this is one of the cases which we had operated. And so this patient, she presented to us with a history of dysmenorrhea, a young girl of around 18 years for almost 3 to 4 years, and has been treated extensively with medical management elsewhere. And with a suspicion of ACUM, she was referred to us with a suspicion of a Mullerian lesion or uterine malformation with unicornate uterus with a non-communicating horn. And as seen here, we can nicely see that the lesion is just below the round ligament, and we have accessed it in toto, and the plane nicely comes up. And to ease the dissection and to decrease the blood loss, we have given a little vasopressin also. And suturing also is pretty easy. Here we are using a barb suture, and we are doing it in 2 layers. Initial layer, and then followed by a inside out a baseball suture. This is relatively easier. And that's the end of it. And this was another patient, and she was also present. She also presented with severe dysmenorrhea, and though the ultrasound showed a small lesion, a 2 centimeter lesion in the lateral wall on the left side, when we put in a scope, we couldn't see the lesion anywhere. In the previous case, we could see it nicely bulging out of the uterine surface, but here we couldn't find it out. So we were in a dilemma as to where to find the lesion. And that is when we thought we'll take the help of the, I'm sorry, it's not playing. So that is when we thought, I'm sorry, it's not playing. I don't know why, for what reason. So what we got the help of the ultrasound machine. We got it inside the OR, and we did a transvaginal scan. This patient, she presented to us with infertility and severe dysmenorrhea, and since we couldn't see the lesion intraoperatively, we used the ultrasound, and the lesion was a very small one on the lateral wall of the on the left side, on the lateral wall of the uterus, and with the help of the ultrasound, we just put in a needle as to exactly where it is, and then I opened it over the if it plays, it will be good. Sorry. I don't know, it's not playing. Sorry. I'm sorry. So that helped us in identifying where the lesion is. So maybe this will, even the literature, people have taken in the help of intraoperative ultrasound to pick up lesions which weren't obvious, so obvious. But most of the times the lesions are somewhere around 2 to 3 centimeters in size, but occasionally they can be even quite small, as in this case. And in our own experience, we have had around 12 to 15 cases which were treated, and the oldest one was the one who presented to me in the 2007 or something. And this girl, she came to us at around she was around 18 weeks when she presented, and she had already undergone surgery for a for a adenomyosis of the ureter per se, and the urology people have done a ureteric reimplantation as it was very close to the insertion of the ureter into the bladder. And she presented to us with severe dysmenorrhea, and thinking it could be only a extensive endometriosis, we put in a TLAP, and to our surprise, we found that the pelvic cavity was absolutely clean, and what she had was a small surface bulge. And I just put in a needle to see what it was, and that turned out to be a chocolate color material. And we put in a hysteroscope, and since we can find anything, then we just left it like that. I just aspirated and left. And that was the time we didn't know that there was an entity called ACUM. And when I went back after the case and read, then it just said as juvenile cystic adenomyosis, and the recommended treatment at that point of time was only aspiration. And this girl, she got married later, and she presented to us 5-6 years later with pregnancy. It was very uneventful. She went and she had even a normal delivery. And I had put her on Depo-Provera as the post-operative management then. And again, after delivery also, we started her on injection Depo-Provera for a contraception. And considering the ureteric history of ureteric endometriosis, I thought it will help her that way also. And this girl, a few years later, she presented 6 months ago, again with a similar lesion in the same place. So this time, when I suggested a surgery, she said she would rather take a medical management, and now I have put her on continuous combined oral contraceptive pills, and she's quite happy with that. So as of now, we are buying time, and before she plans for her next pregnancy. And the other treatment which has been suggested in the literature is ultrasound-guided sclerotherapy, though not many authors have worked on that. And the first therapy was in 2020 by Merviel, and the second author was Naftalin. And Naftalin had actually reported that he had treated 4 women with this procedure, but unfortunately, one of them had a recurrence within 6 months. So that is the evidence we have as of now regarding this sclerotherapy. How we do it? The literature says that it is being performed under a general anesthetic, and a continuous ultrasound guidance. An 18 gauge needle is introduced into the lesion, and this fluid, which is usually very minimal, is aspirated and followed by an instillation of ethanol into the cavity. And there was yet another case report, reported by Pontrelli, and they had used a hysteroscopic resection of the ACUM. This method was chosen by them because the MRI finding was suggestive of a bicornuate lesion, uterus with a cornual hematometra and a non-communicating horn. But unfortunately, when they went in, it was only an ACUM. But still, they went ahead with a hysteroscopic resection. But they themselves have said that they weren't sure whether the resection is complete, and they were worried about the future obstetric outcome of these women, as to whether the pregnancy will go into that small cavity and then she may have a rupture uterus, which is thoroughly acceptable. So now to conclude, ACUM is a rare underdiagnosed pathology, and we need to have that in mind when we treat these young women who present to us with a lesion which is well, cavitated and with a good biometrial mantle. And these women suffer relentlessly with dysmenorrhea, which is not responding to medical management. And the other important thing is we need to do a proper good preoperative imaging, either a 3D ultrasound or an MRI, and rule out the other differential diagnosis which I had just mentioned. And the treatment is so simple. All that you need to do is put in a scope and then just excise the lesion in total, and the patient or the girl is absolutely asymptomatic. And as I had pointed out in our own case, they have a good post-operative obstetric outcome too. And once again, I thank IAGE and Mala for the opportunity. Thank you.
So thank you so much, Dr. Padma. That was a very excellent presentation. So of course, it is very rare presentation, but most of the time it is incidental. We put the scope for something else, thinking it is an adenomyoma or the fibroid, and end up seeing, or sometimes even an adnexal mass, and end up seeing something like an acute. And as I have mentioned even in my talk, like I don't see them on the right side at all. I invariably see them on the left. So what is your thought on it, and why do you think the right side is the most preferred side for acute development?
No, I think that is a misconception. And even in our own, I have around 12 to 15 cases which I'm just planning to publish. And it was a 50-50. Nearly 40 to 45% of them, as is reported in the literature, they had it only on the right side, and a similar number had it on the left side. There is no fixed rule that it has to be only on the right side.
Yeah, but literatures are, if you say acute, it has to be on the right below the round ligament.
No. Yeah, as I was going through the literature for this talk, even the literature also says it's 50-50.
50-50. Okay, right. Fine. Good. Excellent. Good collection of cases also. Very nice.
Thank you. I'm sorry the video didn't play for the second one.
So, Korean sir, so you'd like to add on, sir?
Nothing. I think we've gone a bit beyond time.
Yeah. Okay, sir.
So I think
So thank you so much, everyone. I think it was a very good session. We have covered all the aspects of adenomyosis and its various aspects and management. I would like to thank all our speakers, Dr. Vimi Bindra, Dr. Madhupriya, and Dr. Padma, and also all our chairpersons, Dr. Satyanarayana, Dr. Ghosh, and Dr. Kundavi Shankar, Dr. Meenakshi Sundaram, and everyone. Of course, our chairperson, Dr. Korean sir, Dr. Jairani Kamaraj madam, and Dr. Kundavi Shankar. And I would like to thank all our participants, the delegates who have really attended. So we have more than 80 delegates who had attended this program, and that was really a good number when there are so many webinars happening at the same time all over. So we meet up again with the next month, again with another topic. We will come out with a topic in another couple of days. And if anyone is interested to participate in these webinars as faculty or speaker, please do let us know and write to us. And so I think we call it a day. So thank you so much, Korean sir, for this opportunity. And thank you, IAGE also for the, and Oxy. Of course, this is also along with the endoscopy committee of Oxy. And Meenakshi Sundaram and me are the chairpersons for the endoscopy committee for Oxy. So thank you so much, Oxy, as well. So thanks to everyone. And so we call it a day, and good night, everyone. So I would request all our EC members of IAGE just to hold on for another 5 more minutes. We'll have little more discussions and then we'll wind up. So Ahiti, please hold on for